Welcome back to Medical Monday. I'm here with Dr. Melissa Walko with the Women's Medical Associates of Nashville, talking about babies today and having babies. If you have a question about getting pregnant or being pregnant or delivering, now is your chance to call. 615-737-PLUS is the number to call. Dr. Walko, I want to talk about birth planning. And when you read all these books or go through these apps and say, have a plan, and it's like, you know, what music you want to play and how you want to deliver and blah, 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 blah. How many people come in with a plan like, here's my birth plan?
You know, obviously, you know, I trained in New York City, and a lot of patients came in with birth plans. Okay, so I mean, I don't know an exact percentage, but I would say, you know, maybe 25% of patients came in with a birth plan that they had printed out, written out.
And usually, what do they cover?
They can cover anything, okay? So they'll usually cover, you know, what the patient's plan is as far as pain control, you know, whether they want an epidural, whether they want to try nitrous, whether they, you know, want to go completely natural. It also covers, you know, that they want to avoid a C-section, which is pretty much universal. But, you know, as far as birth plans go, what I tell my patients, you know, a birth plan is a good thing to go over with, you know, you and your husband, so you're kind of on, or you and your partner, so you're on the same page. But as far as your doctor is concerned, just have a conversation with them, you know, prior to going to the hospital. Tell them what your expectations are. Tell them, you know, kind of what you have in mind, because having it written down on a piece of paper, you know, we're there. You can just can just tell me that, you know, you want the epidural, or, and, you know, putting you want to avoid a C-section or a complication on your birth plan. I tell patients, having a birth plan is kind of like having a weather plan for vacation. Sometimes you don't want it to rain, and it just does. You know, so have that conversation with your doctor and trust that they're going to do, you know, what your wishes are and what's best for you.
And I think you brought up a great point about talking to your partner about it, because oftentimes when you're in labor, you can't be like, well, here's what I want. You know, this is my plan and my wish. You're focused on what's happening with your body at that moment, and that partner can be your biggest advocate and the person who speaks for you, right?
No, exactly. And I tell patients, you know, it's kind of becoming, it's a lot more common for men to be very involved in the pregnancy and very involved in the birth, and that's a wonderful thing. And I tell patients, you know, have that conversation with your husband, but don't have it set in stone, because, you know, patients will say, I don't want anything for pain, I don't want any, you know, I don't want an epidural, and, you know, when the time comes for labor, sometimes people change their mind, and that's okay too. So, you know, just tell your husband, this is kind of what I'm planning and what I'm hoping for, but if it doesn't happen, you know, that's okay too, as long as in the end everybody's happy with that healthy, bouncing baby.
Right, absolutely. Let's take it back a few steps before we get to the birth plan part. Let's talk about choosing a doctor, and a doctor that's right for you, because doctors come in all shapes, sizes, and you know, prescribe to certain ideals. So what are some questions that you should be asking your doctor, whether you're trying to get pregnant or you are pregnant, when it comes to who's going to carry me through this season of my life?
Sure. So, you know, patients come in, they always ask one thing, you know, are you going to be the doctor that delivers me? Is it going to be somebody that I've never met? And in general, and certainly in my own practice, you know, I can't be on call, unfortunately, for every single patient. And, you know, I will see you through most of your visits in pregnancy, and, you know, ideally I will be the one that delivers your baby, but unfortunately I have to take some days off too sometimes.
You have a family too.
And the same with my partners, but every doctor will be with partners that they trust and that, you know, conform to the same ideology that they do as far as patient care. So not only that comes down to trusting your doctor. Again, when you pick a doctor and you trust them, you have to trust that they chose partners that are also going to take care of them and have their best interest in mind.
Is it fair to ask, or do you take any offense to asking, like, you know, what's your C-section rate, or, you know, do you do episiotomies, or do you try to not do that? Is it fair to ask those questions?
Of course. I encourage asking those questions, and, you know, every provider will be happy to, you know, kind of give you those statistics as far as what their C-section rate is, what their policy is as far as episiotomies, and, you know, patients will ask me, you know, when would you do a C-section? You know, would you do a C-section, you know, because it's the end of your call and you're about to go home? You know, that's obviously that's not the case.
And VBACs too. Tell me about what's called a VBAC, a vaginal birth after cesarean.
Sure. So vaginal birth after cesarean, you know, it varies from doctor to doctor. So that's 100% if you've had a previous cesarean, you know, you want to ask a new doctor, if you're going to a new doctor that didn't do your C-section before, do you do VBACs? Is that something that your practice does? If you're not the one delivering, do your partners do VBACs? Because that is, you know, a higher risk delivery. So, you know, and of course I would have that conversation with them as far as planning for that VBAC, what to expect, the risks involved.
And what are the risks involved with that?
Sure. Risks involved with vaginal birth after cesarean include the most concerning risk, and the one that I always counsel patients about, is uterine rupture. Okay, so you have a scar on your uterus. Your uterus is a very strong muscle, and when you have a C-section, that muscle is cut open, sewn back together. So that is a weak point in the muscle. And as that muscle is contracting during labor, if the scar separates, that's what we call a uterine rupture. And that can lead to an emergent C-section, and that can lead to an emergency for the baby, a deceleration in the heartbeat. It's also extremely painful and dangerous to the mother.
When you talk about C-sections and plan for a C-section with a patient, someone you know that's going to have a C-section, it's major surgery. I also think isn't it the most common surgery out there, I think, perhaps?
For OBGYN, certainly.
Without a doubt. How do you counsel them on preparing for it?
So I tell patients, you know, this actually happened. My best friend actually had a planned C-section. She had a breech baby, and, you know, I talked to her a lot about this because she was terrified, like most patients are. And I tell them, you know, have the conversation with the anesthesiologist beforehand, okay? So the anesthesiologist in a C-section is your best friend because they're sitting at the head of the bed with you. They're the ones who put your epidural in, and, you know, they'll have the conversation with you as far as the medications that you're going to get. I also tell patients, you know, I go through with them, when you're having the C-section, you're going to feel touching, you're going to feel pulling and pressure and pushing, and that is normal, okay? You're not going to be completely paralyzed from the waist down. You will still feel us, you will not feel pain. You will hear things, you will smell things. You know, try to just prepare yourself for that. Usually they'll have a friend, a family member, a partner in there. I tell the partner, distract them.
Right. Keep talking to them about great things right now.
Exactly.
That's a good way. And then once they go home and you have this great little newborn, but you're recovering from major surgery, what are the expectations the mom should have?
Sure. So it's certainly okay to lift the baby. Obviously, we wouldn't want to do a surgery where you're not able to care for your infant, but really I tell them that's the only thing that you should be lifting. We'll give you pain medication because, again, it is a major surgery. Some patients will be so adamant that they don't want to take any pain medication. They're worried about the pain medication in their breast milk and giving it to the baby. We wouldn't give you any pain medication that would not be safe for breastfeeding. So take the pain medication because you're going to need it for a full recovery. And if you're not taking the pain medication, you can't move around, you can't do things for your baby. Moving around also helps you heal. So, you know, that's what I tell patients to be prepared for.
What about that healing process, whether you have a vaginal birth or a C-section? When should people expect to kind of be like, okay, I'm starting to feel like myself again?
So obviously it's different for the two. After a vaginal delivery, usually most patients are starting to feel that, again, can vary. There are different variations.
Sure, it's a continuum, yeah.
Exactly. So a patient, you know, if they had an episiotomy or if they had a laceration, that can take longer to heal. So a patient will say, you know, my friend had a baby and they felt fine, you know, 2 days later. If you had a big laceration or an episiotomy or another complication, that could take you longer. So I tell patients, usually after a vaginal delivery, you're back on your feet and feeling normal again within about 2 weeks. Cesarean, give it about a month.
Yeah.
And certainly if it's a repeat cesarean section, you know, if this is your second or your third, it's a little bit harder each time, and that recovery takes a little bit longer.
Good information. How do you counsel patients, or does it even matter about having multiple children, whether it's like back to back, does that cause different complications or different worries as you go forward?
Yeah, certainly. I mean, back to the VBAC question, if a patient is planning a VBAC and they have had their pregnancy very close together within a very short time frame, that puts them at an increased risk for those complications, the uterine rupture. So if a patient is planning a VBAC, I do advise them, if you're planning to have a vaginal delivery with your next baby, wait the 12 to 18 months before you get pregnant again, and plan for the VBAC in the future. And as far as a vaginal delivery, I tell patients, for many reasons, not just for your body, for your emotional, your mental well-being, I would tell patients, to wait that 12 months before they start trying to have a baby again. Now, obviously, a lot of women today are waiting later in life to get pregnant, and that's a special circumstance. If you're over the age of 35 and having your first baby, we can talk about having them closer together because time is limited.
Do you find with that second one that labor tends to really go faster, or is that a common myth?
That is definitely not a common myth.
Okay.
That's actually a very common thing. And I actually had a patient in my practice this week who had a baby. She had 3 hours of labor and had her baby, so she's pregnant again with her second, and I told her, you get to the hospital as soon as you start contracting, because that baby's going to come fast. Yes.
And is it true? I mean, your body kind of has done it and knows what it's doing, and it just kind of becomes a little more efficient.
Exactly. Exactly. I mean, that's not universal, but that's definitely more common for the second baby, third baby, and on to come very fast.
Yeah. Okay, very good. We're going to take another quick break. More on having babies when we come back. Stay with us.